Hello everybody, my name is Matt. I'm with Scope Education, and here we're going to be talking about wide complex tachycardias. What is considered a wide complex tachycardia? The QRS complexes can be greater than or equal to 120 milliseconds, and it's obviously going to be over a rate of 100. There's going to be a couple things we're going to be talking about. We're going to talk about VTach versus SVT with aberrancy, AFib with pre-excitation such as your Wolff-Parkinson-White, and we're going to go into your toxic-metabolic issues such as your TCA overdose, your hyperkalemia, and stuff like that. So SVT with aberrancy versus VTach. We see that all the time on Facebook and other medical forums and stuff like that where they're trying to, or pages, and they're all trying to differentiate between VTach and SVT with aberrancy based off of a 12 lead. I'm going to make this super easy for you. Patient's over 55 and has a history of heart disease. Most likely chance is the wide complex tachycardia is going to be VTach is about 98 to 99% chance. The most sensitive marker of origin is not going to be the actual EKG. It's going to be the patient's age or whether or not they've had any history of any heart disease or MIs or anything like that. At least half, if not more, of wide complex tachycardias in even younger populations are going to be VT. VT is more common among the general population than SVT with aberrancy. And we all know SVT with aberrancy just basically means some form of SVT, and SVT is just an umbrella term that encompasses so many different types of rhythms, and aberrancy means that there's a left or right bundle branch that makes it wide. So you're never going to go wrong with treating VT. The reason why is because it is the most deadly of rhythms. So if I throw this up, what do you think that is? Wide complex tachycardia. SVT with aberrancy. And if that's SVT with aberrancy, this must be VTach, right? So you're going to see a bunch of stuff online about the clues that talk about VT and stuff like that. And I mean, if you're in electrophysiology, you can do a little bit more, but emergency medicine is pretty freaking simple. But the clues that they all talk about are just right axis deviation, the taller left peak than the right peak, and your precordial lead, your steeple sign, your fireman's hat sign, AV dissociation. But as I said before, age and history, and if you combine that with AV dissociation, can be the most diagnostic way of determining if it's VTach or not. Here's an example of some AV dissociation. Basically, you can see little P waves scattered throughout the QRS. The atria is still pumping, but it's not correlated with the QRSs. And you can obviously capture infusion beats as well. When in doubt, light them up. That's as simple as you can get. The most effective and safest way of dealing with any kind of like wide complex tachycardia is to light the patient up. Synchronized cardioverter. Stop worrying about, the steeple sign and all the other different types of sign. If you have a wide complex tachycardia, you assume it is going to be VTach until proven otherwise. And here's some little Paul Dorian's philosophy. We don't remember the ordinary things because they're not memorable. What people remember is the 1 out of 20 case that it was SVT with aberrancy, and they forget the 19 out of 20 times it was VTach. Remember, ask the patient's history, their age, and AV dissociation are going to be your 3 big things you look for. Next one, what is this? This was taken from ECG Weekly. If you guys aren't signed up for it, it's an amazing site by Dr. Almola2. Great physician, great lecturer. Absolutely love his content. So go ahead and check that out. That's where I got this EKG from. So what do you see? See a wide complex tachycardia. And if you march that out and look at just lead 1 right here, it looks almost kind of regular, but it's slightly irregular. But if you look over here, you're going to notice that it's wide complex and it's irregularly irregular. At some points, it's even reaching near 300 beats per minute. So what's irregularly irregular and rapid? You got your A flutter, got your AFib, and you got your multifocal atrial tachycardia. Well, I'm telling you that none of those will go at a rate of 300, close to 300. So what is it? It can be AFib with your Wolff-Parkinson-White, your pre-excitation. You can see the QRS morphologies are changing and all this stuff is irregularly irregular. Some are short, some are tall, some are wide, all different morphologies, and that's going to be your key sign for determining AFib with pre-excitation. So what is AFib with Wolff-Parkinson-White? This is just simply a congenital defect, and it creates an accessory pathway called the bundle of Kent. And you get a short PR interval and delta waves on your normal 12 leads, so you can see short PR and that upslurring right here. That's your delta wave. You can see them throughout the entire 12 lead. A little upswelling there as well, but it's mostly prominent over here in lead 1. So that's going to be your Wolff-Parkinson-White. And here's a little diagram. Basically, what the Wolff-Parkinson-White is, the accessory pathway goes down here. This is a floodgate. Patients in AFib, the top part of the heart, the atrium, are going to be contracting at a rate around 400 to 600 beats per minute, and the accessory pathway has no way to regulate it at all. So what is going to be your gatekeeper? The gatekeeper is going to be your AV node, which is going to be very important on how we actually treat these patients. So for treatment, you want to give them some amiodarone, cardizem, adenosine, or procainamide. Which one do you guys want to do? What if I told you if you gave any of these except for procainamide, you get something like this? That's because all of these actually affect the AV node. And as I said before, the AV node is your gatekeeper. If you cancel out that AV node, all 400 to 600 beats are going to go straight down that accessory pathway and send your patient into VFib. That's not fun. Procainamide does not affect the AV node. It's going to actually act on the bundle of Kent. And obviously, if you don't have procainamide, light them up. That's going to be your safest way of dealing with any kind of tachycardia. Just synchronized cardiovertum, and in this case you can also give some procainamide. Now, a lot of people might ask about amiodarone. Amiodarone is typically classified as a class 3 antiarrhythmic drug that primarily focuses on the potassium channels of the heart and are responsible for repolarization process of the phase 3 of the cardiac action potential. Amiodarone is not normally marketed this way, but also affects the beta receptors in the calcium channels and sodium channels as well. The beta adrenergic effect on the AV node will send the patient right in, like I said, procainamide and synchronized cardio with these patients. All right, now we're going to go into the different tricyclic acids. You can kind of look at just a list of the most popular ones right here. They're not as prescribed as they were back in the day, but you still do see them every once in a while. Here's a little TCA overdose. You got a 26-year-old male who took a whole bottle of amitriptyline and he's having seizures and all that stuff, and now he's kind of postictal. Here's his vitals. You got a heart rate of 120, blood pressure's in the tank at 60/40, respirations are 24, temp is 99.4, BGL's looking awesome, and his 12 lead. Well, let's be completely honest. When we do a 12 lead, we mostly do an 11 lead. We love neglecting good old AVR up there, but AVR is very, very important with this kind of patient because you're going to get prominent R wave and AVR in a wide complex, and it's going to be tachycardia. All should be leaning you towards a TCA overdose. As I said in the last slide, here's your 12 lead signs. You got your right axis deviation, you got a wide complex, tachycardia, tall or dominant R wave and AVR, and your QTC is going to get prolonged because it's widening. So how are we going to treat these patients? We're going to give bicarb, and more bicarb. Those are going to be the most important ones. Your benzodiazepines for any kind of for your seizures, and then you're going to do a slight hyperventilation with these patients. So if you're assisting ventilations with them with a BVM mask, you're going to hyperventilate them just a little bit. Aim for a pH of 7.5 to 7.55. That's going to be your golden range dealing with any kind of TCA overdoses. These aren't super common, but it's a wide complex tachycardia that we should know how to treat. And just always think ABCs, it should be like the Jackson 5 kicking in your head right now. Next we have this. We have a wide complex tachycardia, right? But what is different about this wide complex tachycardia? This is what Almoma 2 calls a regular, really wide complex tachycardia. It is the QRS is over 1 big box wide, which makes you kind of worried about hyperkalemia. The only thing that can get you over 1 big box wide is going to be your tox or metabolic issues. In this case, it's going to be your hyperkalemia. Hyperkalemia treatment. So how are we going to treat it? Well, if you guys want to do a more thorough, in-depth video on it, I'll link it up in the corner. It's going to be the hyperkalemia video I've already done. So I won't go too much into this because you guys can just look at that video for the more in-depth version. Basically, calcium is going to be your best friend. Please use calcium. It will stabilize that myocardium. And then obviously you got your sodium bicarb, your D15 insulin, and albuterol, which is best used in conjunction with your D50 and insulin. When you're thinking about bicarb, a lot of us have the 8.4% hypertonic in nature. If you have a more isotonic bicarb, you can give that because more hypertonic bicarb has a chance of solvent drag, and we don't want to do that. Basically, that pulls potassium into the cells, and then they just slowly fall back out into the serum, and it doesn't really help you. Make sure it's more isotonic if you are going to give it. That's at least what some of the studies are saying, so there's still a little debate on that, but the number one thing you're going to be doing is calcium. Why you need to recognize hyperkalemia on a 12 lead and not infer it as VTAC. So we're back to this 12 lead, right? So if you saw this wide complex tachycardia and you thought it was just VTAC, remember VTAC is usually around 120 to over 120 to 130 beats per minute, usually over that, but that's depending on the literature you read. I personally prefer to use 130. That's the most safest option for me, and it also prevents you from giving medications for your idioventricular rhythms. So if you're thinking about this in an ACLS standard and you have a wide complex tachycardia, right, you're going to think, and the patient's stable, and you want to give amiodarone or whatever to these patients, right? Well, hyperkalemia is thought to be a sodium channelopathy, which means just the sodium channels are poisoned. Amiodarone is a common medication that we give for wide complex tachycardias, and if you give it to this patient, congratulations, you killed them. Remember that amiodarone is classified as a class 3 antiarrhythmic drug that primarily focuses on the potassium channels of the heart that are responsible for the repolarization process in the phase 3 cardiac action potential. Amiodarone normally is not marketed this way, as I said before, but it also acts on the beta receptors, the calcium channels, and the sodium channels. Would we want to block and harm the sodium channels more in a poison sodium channelopathy? No, we don't. So please don't give this to your patient. It will kill them. So for a little recap, SVT versus VT, always just treat the patient for VT. If you have any questions about it, just synchronize cardiovert them. It's okay. It's safe. Always treat the most deadly of the rhythms, which is going to be your VT, obviously. Next, your irregular rhythms with signs of pre-excitation, such as your altering QRS complexes and rates nearing 300 if you're procainamide, light them up. So you got shock for SVT and VT, and you got shock for pre-excitation, AFib with Wilcoxon White. What are you going to do for your TCA overdose? You do a thorough history and assessment, and you need to know the signs on a 12V. The dominant R wave, the widened QRS, the right axis deviations, all going to point towards your overdose, along with a whole bottle of amitriptyline. And then regular, really wide, complex tachycardias, always assume hyperkalemia. If the words wide and bizarre ever enter your mind, you think hyperkalemia all day long. You have a wide, complex tachycardia, and it's regular, and it's around 120 and maybe 130. Patient stable, give them some calcium. And if the QRS complex narrows before your eyes, I promise you it's not VTAC. And there's no real harm in giving calcium to patients. You just made their bones stronger. If it doesn't, then treat it as VT. Don't worry about SVT with Aberrancy. Always treat it VT, okay? As I said, my name is Matt. If you want to read about this, we have our own website, scopeeducation.training. We'll have it linked down in the description below. I actually already have an article on this already, and I'll just tag it in there as well. You can read this if you want to, or you can check out our website for more other free open access medical education. I've gotten some requests to do some kind of merchandise, so me and the other person who's helping me out with Scope Education, we got some stickers, which I'll show up right here. And if you want one, feel free to just email me, go to scopeeducation.training and send us a message there. I do have some exciting news though. We are looking into getting some podcast stuff, so there might be some podcasts in the next couple months or so just keep an eye out for that. We do have a Facebook, we do have a Twitter, it will be down in the description, so if you want to, go ahead, check that out. If you guys like this video, like it, subscribe, do whatever you want. I hate it when people ask that, but I feel like half the time I always forget. So anyway, like I said, my name is Matt. I hope you guys enjoyed this lecture, and you guys have a good one.